Most highly competent international medical graduates operate under a dangerous illusion regarding the OET Speaking subtest. When they look at the criteria on your screen, specifically Clinical Communication Criterion C1, Relationship Building, they assume this simply means being unfailingly polite, maintaining a warm tone, and sympathizing with the patient. This is a fundamental misunderstanding of how examiners score this exam. If you attempt to pass Criterion C1 simply by acting like a patient's best friend, you will trigger a catastrophic timeline collapse. In a highly pressurized 5-minute clinical simulation, excessive social politeness is a structural hazard. Examiners are not grading your bedside manners. They are grading your ability to execute a shared clinical pathway. In this video, I am going to dismantle the two most common relationship building pitfalls that cause advanced English speakers to fail at 340, and I will project the exact verbatim mechanisms you need to secure your C1 score without sacrificing a single second of your timeline. The first major error usually occurs within the first 60 seconds of the consultation. We call this the open-ended empathy pitfall. When a role-play card presents an acute, highly anxious, or physically distressed patient, candidates often freeze. Their generic English textbooks have taught them to deploy prolonged, repetitive expressions of sympathy. Observe the live acoustic intercept on the right side of your display. Watch as a candidate falls directly into this hazard.
Oh dear, Mr. Jones, I am so incredibly sorry to hear that you are in such terrible pain. That sounds absolutely dreadful, and I can completely sympathize with how awful that must be for you right now. Please tell me more about how this makes you feel.
Look at the consultation clock. That single empathetic response just burned 15 seconds of valuable diagnostic runway. But worse, by finishing with the phrase, "Tell me more about how this makes you feel," the candidate has effectively handed the steering wheel of the consultation over to a panicked patient. The patient will now launch into a sprawling, non-clinical narrative, and your structure score will hemorrhage. True clinical empathy is concise, professional, and strategic. You must explicitly acknowledge the patient's distress, validate its severity, and immediately bridge forward. You are validating the patient to close the emotional loop, not to expand it. Instead of generic sympathy, a passing candidate executes immediate clinical validation. Analyze the structural architecture of this masterclass alternative on your screen.
Mr. Jones, I can see how distressing this pain is for you, and getting it under control is my absolute priority today. To safely authorize your medication, I need to ask a few targeted questions and then we will move straight to your treatment.
Analyze the mechanics. It is profoundly empathetic, but it is structurally immovable. It acknowledges the pain, links it directly to an immediate medical solution, and explicitly limits the diagnostic timeline. You have secured your C1 relationship building mark for empathy, whilst maintaining total clinical command of the room. The second major C1 failure occurs after the 3-minute mark, during the collaborative management phase. When candidates realize the clock is running out, a psychological panic sets in. To ensure they clear every medical task on their card, they drop their empathetic tone entirely and execute what we call the Authoritarian shift. They begin to dictate. Look at the vocabulary in this failing execution.
I am going to prescribe you this medication and you must take it twice a day. You also need to stop smoking immediately, and I want you to book a follow-up appointment for next week.
Listen to the acoustics of that phrasing. Look at the separation pronouns on your display. I and you. I am going to. You must. It sounds exactly like a headmaster giving orders to a disobedient schoolchild. It creates immediate psychological friction and places the entire burden of compliance on the patient. The examiner will instantly penalize your relationship building score because you failed to incorporate the patient's perspective. You are dictating a plan, not negotiating one. The transition from an authoritarian dictation to a shared clinical dialogue requires a fundamental mechanical shift in your vocabulary. You must completely eliminate the separation pronouns I and you from your management proposals and replace them with the collective pronouns we and our. Listen to the pacing and the collaborative framing of this masterclass correction.
To get this blood pressure down, we need to look at adjusting our approach to your diet. Let's look at how we can fit this new routine into your daily schedule.
By deploying collective pronouns, you linguistically position yourself on the same side of the table as the patient. You are no longer an authority figure handing down an order. You are a medical partner solving a shared problem. When you combine this pronoun shift with an open verification question, such as, how manageable does that first step sound to you? You force the patient to take active ownership of the clinical pathway. This is exactly what the assessors are looking for when they grade criterion C1. Relationship building in OET medicine is not about small talk, it is about clinical partnership and timeline protection. If you are consistently struggling to control talkative patients, or if you find yourself rushing and dictating your management plans because the clock is running out, your timeline mechanics are fundamentally compromised. Do not wait until test day to find out if your pacing is going to trigger a 340 score. Click the link in the description below to run my free timeline integrity audit. This interactive tool will calculate your exact risk of a structural collapse under exam pressure and show you precisely where your consultation layout is failing. Take the audit, lock in your structural framework, and I will see you in the next video as we decode criterion C2.